Thank you for attending the conference today and for your generous support of GPEC. It's hard to believe when I started working at the Princess Margaret Cancer Centre about 13 years ago, I joined a team of only one palliative care physician and 2 nurses, covering palliative care across 3 hospitals. Today, I'm proud to say that I lead a team of 14 palliative care physicians across the University Health Network. In addition, we have an interdisciplinary team of nurses, social workers, psychiatrists, psychologists, and allied healthcare professionals who provide counseling and tailored support for patients and families living with a terminal illness. We provide care in outpatient clinics, on oncology and medical wards, in our specialized tertiary palliative care units, and at our hospice. There was a time when people would receive a terminal diagnosis and be offered only immediate treatment options without any in-depth discussion around how to handle physical symptoms such as pain and trouble breathing, or emotional issues such as fear, anxiety, or uncertainty about the future, and especially not about the possibility of death. Once treatment options were exhausted, people were left to visit emergency departments in panic or spend their final days at home without any medical support. As our population ages and people become more aware that they can plan ahead for how they wish to experience the end of life, it is more and more critical that we continue to develop palliative care and make it increasingly accessible both in North America and abroad, not only at the end of life, but throughout the course of any life-threatening illness. The field of palliative and end-of-life care encompasses a wide range of medical care and support. It includes ensuring to the best of our ability that people have access to pain medication and medication for other physical symptoms, that they have adequate community support, that they're supported to work through feelings of anxiety, fear, grief, and loss, and relationship or family concerns, and they have the opportunity to plan for where they wish to die, whether it be at home, in a hospice-like setting like Kensington, which you just saw in the video, or in a hospital. We know this approach works. A large trial led by myself and our team at the Princess Margaret and published in The Lancet last year found that providing early outpatient palliative care for patients with advanced cancers improved both their quality of life and their satisfaction with medical care compared to standard oncology care. And there's been other studies in the US that have shown that this approach reduces depression and even improves survival. It's been incredibly inspiring and rewarding to see this field grow and to work with patients and families so they can experience as much peace and comfort as possible during a time that is frightening, daunting, and often painful. We still have work to do, but we feel we're at a place where we can contribute what we've learned, our ideas and our expertise, to help advance access to the medical aspects of palliative care and to critical psychosocial support. In turn, we have much to learn from our international partners who can contribute new ideas and thoughts about how we develop this field in Canada. By bringing together thought leaders from a myriad of disciplines, GPEC will expand research, inform policy, and ultimately contribute to training and growing expertise and care around the globe. Philanthropy has allowed us to develop an internationally recognized program at the Princess Margaret, and it will be essential to growing GPEC and moving it forward. So thanks again for your support and for recognizing the importance of advancing psychosocial, palliative, and end-of-life care. Enjoy the rest of the conference.